I'm Dr. Marc Lubitz, and today I'm going to be giving my grand rounds presentation on elbow ulnar collateral ligament reconstruction. Our story starts with Dr. Frank Jobe. Dr. Jobe was born in North Carolina and enlisted in the Army in 1943. He served as a medical staff sergeant in the 101st Airborne Division and landed with Allied forces at Normandy in the D-Day invasion. He continued to serve with the Allies in Europe and was captured by Nazi forces during the Battle of the Bulge. He ended up escaping and was awarded a Bronze Star for his service. After the war, he utilized the GI Bill to go to undergrad and then medical school at Loma Linda University before doing his residency in orthopedic surgery at LA County Hospital. In 1964, he teamed up with Dr. Robert Kurlan in Los Angeles, and they formed the Kurlan-Jobe Institute. They became team doctors for the Los Angeles Dodgers in 1968. In 1974, while pitching for the Dodgers, Tommy John tore his UCL. At that point, players could either try to rehab and play through the injury or retire. Dr. Jobe performed the first ever UCL reconstruction on Tommy John, changing the narrative of how this injury is treated. He actually suffered a dense ulnar nerve palsy for 3 months postoperatively, which required an exploration and ultimately transposition to recover from. After 18 months of rehab and recovery, he returned to pitch for the 1976 season. Remarkably, after this return, he went on to pitch for 13 more seasons until age 46. He not only pitched, but pitched very well, being named to the All-Star team 3 times and finishing high in the Cy Young voting. Dr. Jobe continued practicing for many more years, helping countless athletes return to competition and revolutionizing the care of baseball pitchers. He passed away in 2014 at age 88. So why is this such an important topic in sports medicine? It starts with the fact that MLB pitchers are cumulatively paid over $1.5 billion per year, and around half of them end up on the disabled list at the end of every season. Right now, in Major League Baseball, around 1/3 of pitchers have undergone Tommy John surgery, and UCL tears continue to rise in incidence in young pitchers, especially those in high school and college. So, as always, the first place to start in orthopedics is with the anatomy. The UCL is made up of 3 bundles, the anterior, posterior, and transverse. The anterior bundle is the primary restraint to valgus stress at the elbow from 20 to 120 degrees of flexion. The posterior bundle acts as a secondary stabilizer beyond 90 degrees of flexion. The anterior bundle itself is made up of 2 bands, the anterior and posterior. These bands function reciprocally, with the anterior band being stronger from around 30 to 90 degrees of flexion, with the posterior functioning mostly at 120 degrees. The posterior bundle is mostly irrelevant except for the fact that it can be released to improve flexion in stiff elbows. The transverse bundle does not actually cross the ulnar humeral joint, and at this point does not have a known function. So looking here briefly at the bony anatomy, the elbow is a hinge joint with 3 articulations, the ulnohumeral, the radiocapitellar, and the radioulnar. It moves in flexion and extension and pronation and supination, and has a normal valgus carrying angle of around 15 degrees. Here you see the flexor pronator mass inserting onto the medial epicondyle. The dynamic action of this muscle group provides a varus moment which helps the UCL to resist valgus stress. In a UCL deficient elbow, the FCU and the FDS provide the most valgus support. The Polymerase Longus is relevant here as it is the most common graft used for reconstruction. The Polymerase Longus is congenitally absent in around 15% of the population. You can test this by having the patient oppose the thumb to the small finger. It's also important to note the proximity of the Polymerase Longus to the median nerve. Disaster can occur during graft harvest if the nerve is mistaken for the Polymerase Longus. The median antibrachial cutaneous nerve is relevant here in that it's at risk during the approach. It comes off the medial cord of the brachial plexus, enters the forearm with the basilic vein, and is responsible for medial elbow sensation. If injured during the UCL approach, it can cause painful neuromas and sensory loss. The ulnar nerve is the most important neurovascular structure at risk during this procedure. It descends posterior medially down the humerus and into the cubital tunnel posterior to the medial epicondyle. It gives off articular sensory innervation and then enters the flexor compartment of the forearm through the 2 heads of the FCU. It's important to be especially cautious in patients who have previously had surgery and may have undergone ulnar nerve transposition. Ulnar neuropathy remains the most common complication after UCL reconstruction, epitomized best by Tommy John's palsy that required a return trip to the OR 3 months post-op. Identifying the ulnar nerve is a key step in the exposure for reconstruction. So we'll move on to the second part of the talk here, which is biomechanics. So why do humans throw? This is an article published in Nature in 2013 that details the development of throwing ability in modern humans. It's thought that several anatomical features which enable elastic energy storage about the shoulder allowed for throwing to develop in primates around 2 million years ago. Early humans were carnivores, but lacked natural weapons like fangs or claws and are relatively slow and weak compared to other carnivores. The ability to throw projectiles enabled hunting other animals. The authors of this paper suggested that elastic energy storage in the shoulder is the main driver of this ability, aided by the unique anatomical features not found in earlier primates. During arm cocking with shoulder external rotation and abduction with the elbow flexed, the short parallel tendons and ligaments, along with the muscles of the shoulder, are put on stretch and aggregate elastic energy, which helps to power the extremely rapid internal rotation of the humerus needed for throwing. Humans differ from other primates in that we have tall, mobile waists which decouple the hips from the thorax and allow for significant torso rotation. Secondly, humeral torsion in humans is 20 degrees lower in the dominant throwing arm compared to chimps, which allows for increased external rotation at the shoulder and thus more elastic energy storage at the shoulder. Lastly, humans have a laterally oriented glenohumeral joint, aligning the pool of the pec major along the same axis as the torso rotation. Chimps have a more cranially oriented glenohumeral joint and limited torso rotation. This causes chimps to further abduct their humerus and then extend their elbow to throw, which greatly decreases their efficiency and energy storage when trying to throw. The figure on the right highlights the effects of humeral torsion on throwing. Lower torsion allows for more external rotation, which enables more elastic energy storage for throwing and faster projectile speed. Humans and chimps have comparable degrees of torsion except for in throwing athletes who have reduced torsion in their dominant arm, which is an adaptive change that occurs as the throwing athlete develops. Briefly here, we'll dive deeper into the concept of humeral torsion. It's important to understand the normal development in humans. Humeral torsion is defined as the rotational difference in the relative position of the humeral head and the axis of the elbow at the distal humerus. Normal for adult human retroversion is between 25 and 35 degrees. At birth, the humeral head is markedly retroverted and undergoes a process of derotation, decreasing retroversion during pediatric and adolescent years. There are opposing rotational stresses imparted by muscular forces above and below the proximal humeral physis. These rotational stresses result in an adaptive response that derotates the humeral head and reduces the degrees of retroversion during growing years. This process occurs most rapidly up until the age of 8 and then slows down, approaching mean adult values by around 16 years old and ultimately ending with closure of the physis at skeletal maturity. The dominant shoulder tends to demonstrate a greater degree of humeral retrotorsion. Adult throwing athletes have larger side-to-side differences than non-throwing athletes, implying that the act of throwing decreases the amount of derotation that occurs. The cause of these changes are due to the internal rotation torque of the proximal humerus versus the external rotation torque at the distal humerus, which occur during throwing. In a skeletally immature athlete, the proximal humeral physis is able to adapt to these changes and decrease the amount of derotation that goes on. In summary, the forces imparted onto the proximal humeral physis during throwing decrease the derotation of the humeral head in young athletes. This leads to a more retroverted humerus in the throwing arm, which reflects this adaptive change. Ancient hunters certainly threw less frequently than modern athletes, who throw up to 100 miles an hour repeatedly over the course of a few hours. While the ligaments, tendons, and muscles about the shoulder are designed to elastically store energy and facilitate throwing, they are not designed to withstand repeated stretching and the high torques generated by throwing. The repeated overuse leads to ligament laxity and tearing and reflects the throwing injuries we see in modern athletes. Dr. Glenn Fleissig at the American Sports Medicine Institute in Birmingham, Alabama said, "It's not because throwing isn't natural. What's not natural is throwing 100 pitches from a mound on every fifth day. That amount of throwing at that intensity is not natural." So here we'll go through the 6 phases of throwing. Throwing starts with a windup, which is variable between pitchers and situations. It starts with balancing on the push-off leg, which is the same leg as the dominant arm. The stride leg is flexed, and the elbow is flexed and pronated. Next is early cocking. The shoulder begins to abduct and externally rotate. The leg begins to push off, and kinetic energy flows through the hips and the pelvis. The upper trap and the supraspinatus are firing strongly, and the elbow is flexed at 90 degrees. Late cocking is characterized by maximal shoulder abduction and external rotation, with the elbow flexed 90 to 120 degrees and the forearm fully pronated. You see here the highest activation of the subscap and the serratus anterior. Acceleration consists of rapid internal rotation and adduction, and generation finally of that forward force. Valgus force at the elbow up to 64 Newton meters is recorded during late cocking and acceleration, which is nearly double the varus torque the UCL can provide by itself in the lab. The rest of that torque is provided by the flexor pronator mass and the radiocapitellar articulation. Deceleration starts with ball release, and then all the muscles around the shoulder maximally fire to decelerate the arm. The elbow gets to about 20 degrees shy of full extension. Follow-through is characterized by the dissipation of the excess kinetic energy and the elbow reaching full extension. Here we'll see a slow-motion video of Aroldis Chapman pitching for the Reds. Try to sync up his motion with the phases of throwing. So here he's beginning his windup. Again, this is extremely variable between pitchers and differs on the situation in the game. Now he starts to bring his arm back. That's early cocking, late cocking as he reaches maximal external rotation, and then quickly acceleration and deceleration. Follow through here. So again, the UCL is the primary valgus stabilizer of the elbow. In the lab, the UCL in isolation is able to produce 32 newton meters of varus torque prior to failure. Pitchers are required to produce a maximum varus torque of around 64 newton meters every time they throw the ball. That's twice what the UCL is able to handle in isolation. You start to get a sense that repetitively stressing the UCL to its maximal force is going to cause issues. Briefly, this is a study that I worked on with Dr. Madgett and Dr. Troy's group at Worcester Polytechnic Institute. We utilized a technology called high-density mapping to analyze strain patterns in the ulnar collateral ligament. This new imaging technology uses the deformation of pixels to deduce strain and was originally developed to measure the changes in heart strain after ischemic events. We used it to analyze ligament strain for the first time as a repurposing of this imaging technology. We showed that UCL strain increases with flexion, especially greater than 90 degrees. We hope to continue to use this imaging modality to further evaluate strain in the UCL and strain in UCL reconstruction. This was one of the first studies published about the biomechanics of pitching, done by Dr. Pappas at UMass back in 1985. They analyzed 15 MLB pitchers with what they called high-speed cinematography and analyzed 147 pitches. They described three distinct phases, being cocking, acceleration, and follow-through, essentially the same as what we have today. They noted, like we talked about earlier, that wind-up and early cocking is extremely variable between pitchers and situations, but once you get to late cocking, it's nearly identical. This study by Dr. Fleissig down at ASMI further characterized the amount of force across the elbow during throwing. They noted that the bony articulation accounts for around 50% of the overall elbow stability. For varus stresses, the ulnar humeral joint is the primary stabilizer, and it's aided by the 15-degree valgus carrying angle. Conversely, the radiocapitellar joint is only a secondary stabilizer to valgus stress, playing a minimal role compared to the UCL. As previously mentioned, the anterior bundle of the UCL is the most important, providing resistance to the torque of throwing. It's the primary stabilizer from 0 to 90 degrees of flexion. After 90 degrees, the posterior bundle is the primary restraint, though it does provide some assistance starting at around 60 degrees of flexion. You can see here that there's not much difference in overall throwing force across the elbow based off of different pitches. We talk about not letting kids throw curveballs at a young age, but that is actually not really panned out in the UCL literature related to UCL injury. The faster you throw, the more force is required to accelerate the ball, which thus puts more force in the UCL. Naturally, that means the fastballs have the highest force. However, curveballs have been shown to correlate with Little League elbow and shoulder as they put more torque on the physis. Next up, we're going to talk about the kinetic chain, which is an extremely important topic to understand related to UCL injury. The kinetic chain is a rapid coordinated progression of muscle activation and force development that starts in the legs and proceeds cranially to the arm. Dr. Pappas writes in his seminal paper, "As each segment beginning with the foot is accelerated, the succeeding segment first acquires the speed of the segment moving it, then accelerates to an even greater speed. The shoulder then harnesses the forces from the lower extremity and directs them to the arm. The forearm muscles work to fine-tune ball release while the shoulder is directing the force. This occurs in conjunction for pitch control. The kinetic chain is also important positioning the elbow adventitiously, avoiding positioning the elbow below the shoulder, which puts more stress on the elbow. This basic physics concept helps me understand the kinetic chain. If you're traveling in a car at around 60 miles an hour and you throw a baseball outside the window traveling 50, the ball's not going 50 miles an hour. It acquires the speed of the car first, so it's additive. It's going around 110 miles an hour. The muscles of the upper extremity themselves can't generate enough force to throw a fastball 100 miles an hour, but when coupled with the energy generated by the lower extremity and the trunk in conjunction, they're able to accelerate the ball as needed for high-level baseball pitching. Thinking about the kinetic chain certainly leads to further questions. Since force generation for throwing starts in the lower extremity, is it possible that lower extremity injuries either result in or result from UCL injuries? This study out of Columbia looked at proximal lower extremity injuries of the hip, hamstrings, and groin in MLB pitchers who had undergone UCL reconstruction. 27.6% of that group had spent time on the disabled list for hip, hamstring, or groin injuries, compared to 17.9% for their control group, which was a significant difference. So, does an injury to the UCL cause a lower extremity injury, or are the lower extremity injuries causing injury to the UCL? The theory is that this is related to the kinetic chain. If your lower extremity is malfunctioning, you'll put more force on your elbow. Is this potentially modifiable to prevent and/or rehab from a UCL injury? Those are the next steps in this research. We tried to replicate this study in a cohort of mostly college-age pitchers from a group in Cincinnati. We retrospectively reached out to pitchers who had undergone UCL reconstruction and showed a 32.8 incidence of proximal lower extremity injury compared to 17.9% in those MLB cohorts of controls. Our study had a lot of limitations, but potentially implies that this correlation is present at all levels, not just in the MLB like the Columbia group showed, and may be a relevant target for prevention and rehab of UCL injuries.